patients' skin lesions. They had, just like when you have any viral exanthema, like viral diseases, skin is involved, so you can have skin rashes or skin lesions. And one of my patients presented yesterday with a skin lesion, actually on the face and also on the hands. So that's something to think about, keep in mind, because COVID-19 seems to have atypical presentations. And these patients are so fresh in my mind, I thought I'll share it with all of you. And one more thing is repeated shaking with chills. That's a new one of the new symptoms also that we are seeing. We've not seen, of course, we've seen fever and we've seen chills, but this is like repeated shaking, and they can have chills. They can have bluish lips and bluish tongue because of the oxygen numbers being on the lower side. So that kept apart, coming back to your question regarding remdesivir. This is given for patients who are critically ill in the hospital. They are actually, as you know, mild to moderate patients comprise 80 to 84% of the COVID-19 patient population. The rest, around 16 to 18%, are the ones who are severely ill and critically ill. So the patients who are in the intensive care unit on ventilators, okay, they could be receiving the medication called remdesivir. And as you correctly pointed out, this was on trials before for Ebola virus, and not much was known at that time. But now, because it's gaining a lot of, we have very limited treatment options here for COVID-19, and remdesivir seems to be helping. It's an antiviral medication. It helps with reducing the viral replication, and that's how it's helping. And we've seen a lot of promising trials on that it is helping in the intensive care and critically ill patients on ventilators, or even who are needing less, who are oxygen numbers are very low. And in those patients, there was one article which came out of China saying against remdesivir, like how much can it help in ventilated patients. So there's still controversy, but for now, the promising treatment seems to be remdesivir along with convalescent plasma.
So, Dr. Mupanna, is that a remdesivir, does it have a best chance of working in patients who are treated early, like before the disease becomes severe, or is that true?
So before the disease becomes severe, remdesivir is one which could be helping, and the other one is the convalescent plasma also. There are lots of controversies on how early can you give these medications. Can we start it early so the cytokine storm and patients don't develop that and don't become too ill, and then we are kind of chasing the tail here, right? There are thoughts about that, but so far where it is indicated is in patients who are critically ill and who have all the CAT scan findings. Their oxygen numbers are very low, they are intubated, they're on a respiratory support system, on ventilators, and also on a heart-lung machine outside the body to keep up with their heart functions and to keep up with their oxygen functions, like the ECMO. It's the extracorporeal membrane oxygenation system. So those are the patients who are receiving it. You do have to get approval from your hospital board. So every hospital board in Massachusetts, they have their own policy in the board, and it depends on their board, actually. They have to make the decisions as well. It's not like hydroxychloroquine or azathioprine, where only the infectious disease doctor and the pulmonologist, they can look at the CAT scan findings, look at the criticality of the patient, and then decide and give. But this needs a little more higher level of involvement in terms of the healthcare administrators.
Thank you, Dr. Mupanna. Dr. Shah, do you want to share here something, your thoughts about how promising remdesivir will be?
Absolutely. I think what we are seeing is, as Dr. Mupanna just mentioned, that with COVID-19, we are seeing a lot of mixed results with remdesivir, but that is the one medication which we are seeing a lot of relatively early success in moderate to severe cases in hospitals. I know recently the study in China a couple of days ago did not reveal positive findings, and study was concluded early, but that is just one study and one geographic region. So as Dr. Mupanna mentioned, I think that is one drug which we are eyeing very closely in medical community, apart from looking for long-term resolution through vaccines and some of the other measures. But it is extremely key to practice social distancing right now and find the COVID-19 in early stages where it becomes mild to moderate and can be treated in outpatient settings. Even though there are no medications, there are many things you can do, as Dr. Mupana has covered it in the past, to help mild to moderate conditions at home.
True. Yeah. Thank you, Dr. Shah. Coming to our second segment, I want to, before we even talk about that, I want to say in the months since this coronavirus exploded into a pandemic, we have heard a range of stories about those who have been stricken by disease, the vast majority with mild symptoms, but increasing number of needing to be hospitalized. It's becoming increasingly clear that even when the pandemic is over, it won't really be over. So for the sickest patients, infection with the new coronavirus it's proving to be a full body assault, literally causing damage well beyond lungs. And even after patients who become severely ill, they have recovered. And, we saw, that cleared the virus, but physicians have begun seeing evidence of infection lingering. So infection lingering effects. So my question for you, Dr. Saras, what do we know about coronavirus long-term effects?
Yes. So coronavirus, it is a virus and it follows the path, it seems to, at least for now, follow the path of other viruses in the way it affects the lungs. So when it comes to the lungs and critically ill patients, it causes something called ARDS, acute respiratory distress syndrome. It's because of the surge of the inflammatory markers, again, the interleukin 6, which go into the capillaries of the lungs and cause damage to the lungs, right? And fortunately, we are always talking about the number of patients affected and the number of deaths, but a good proportion of the patients are also recovering. So that looks promising. So when the patients recover, right, they're on a ventilator, they could be on an ECMO, as I mentioned earlier, or maybe they're not on all these measures, but they're still severely affected. The lungs are severely affected. It can form scarring in the lungs. Okay, we don't know what percentage. We don't know what percentage of severity will cause what percentage of long-term effects. We don't know that yet because it's too soon to comment on the long-term effects. But overall, what they're seeing, my other pulmonology colleagues, what we are seeing is it can form some scarring. It can have patients might need, when they're getting discharged and going home or to a facility, they might need long-term oxygen, and home oxygen therapy. That's one thing that they might need. And they might be so deconditioned because they've been on a ventilator. The nutritional status has to be taken into account because that's what is going to help them with the conditioning of the body. And it can also form, as I said, reduced oxygen numbers and cognitive effects. So whenever previously, even before the pandemic, the studies have shown in patients who have ARDS and who have been on ventilators coming out of the intensive care unit, they have all these problems along with cognitive dysfunction. So they can have memory loss, and it takes time. It needs good support system. So it takes a lot of time for all these things to get back into form, and they could be out of their job for some time. Okay, it depends on the status and the condition what they're getting discharged home in. So those are all the things that the family and the community as a whole need to keep in mind and see how can a patient who's done well, came out of the ventilator, came out of the intensive care unit, now is back into the community. How well are we going to be able to support this patient because they are going to need some long-term care? Okay, and of course, other precautions have to be taken. Like if they are a COVID-19 patient and you're bringing them home, make sure that all the other CDC precautions like wearing masks, 6 feet distance, their own bathroom, bedroom, utensils, and the laundry, and one person going and taking care of them. So all these measures have to be kept in mind as well. But the most important things are maybe they need long-term oxygen at home, and they could be deconditioned. Nutritional status has to be kept into par, and they could also have lung damage and also heart. We've also noted that heart can be affected as well. So heart problems can happen, and the kidneys also can be affected. I don't mean to draw a scary picture here, but those are the things that we want to bring because it's an awareness session. Those are the things that I want to bring into mind.
And Dr. Mupana, does it also develop blood clots?
Yes, it also develops blood clots even in the intensive care unit. What happens is when the inflammatory surge happens, they can actually block the blood capillaries, the smaller capillaries, the blood vessels, and they can form blood clots. And you must have heard of patients with COVID-19 who had symptoms and are at home, and sudden death seems to be happening in them. That could be because of the arrhythmias, irregular beating of the heart. It could be because of that. It could also be because of the clots from the legs or hands, and they can reach the lungs. That's called pulmonary embolism. And patients can have sudden death because of the pulmonary embolism. So the standard of care has become now, at least in the Boston hospitals where I'm affiliated with, they give therapeutic anticoagulation, a blood thinner at a therapeutic dose to prevent these clots. Thank you for mentioning.
Yeah, and Dr. Shah, any a few words on your what you think are the long-term effects?
So I think I want to piggyback on what just Dr. Mupana mentioned about the lot of the chronic ailments or the extra pulmonary or extra respiratory elements we are seeing with COVID-19. A lot has to do with pre-existing conditions also. And I think as far as we are seeing some long-term sequelae, I think this is where the community members and community providers, such as primary care providers and other ambulatory care providers, whether it is a home health care agency or a visiting nurse association or even friends and family. I think they all have to do their part, because not only COVID positive patients are coming home from hospitals, the biggest challenge we are seeing is, as Governor Charlie Baker mentioned on a Thursday press conference, that there are 18,000 Boston hospital beds available. Half of them are empty. And those numbers don't add up, because with coronavirus pandemic, the need for dialysis, need for chemotherapy, need for cardiovascular conditions, need for other non-COVID care suddenly hasn't gone away. And I think this is where we have to do our best as a community, that we do not succumb ourselves to the fear of corona and go back to what we already know has worked. We are a strong community, especially in Boston and New England, and we are seeing some lot of great care models emerging in New England, where people are getting care at home, a hospital grade care, which they never used to have available before. So as a lot of these advances are happening, the long-term sequela, what I see is the biggest thing we have to prepare for is the next surge, when and if it happens. We don't know at this point if the next surge is going to happen, but there are a lot of indications that it will most likely happen after the summer. So it gives us opportunity for next 3 to 4 months to build the infrastructure, to build the awareness, build the community competence around how to take care of our friends and family at home with the medical grade technology and advances in care models. But at the same time, do not, we have to seek care when it's appropriate. So I think this is the biggest message, that please go and talk to your primary care doctor, your regular specialist. If you had Dr. Mupana as your pulmonary specialist and you had, let's say, a sleep apnea, suddenly you should not be shying away and staying at home and not engaging. I think engagement is the key. Once you engage with the medical providers, you will hear a lot more positive things about how you can do your part to stay healthy. Because at the end of the day, this is just another virus. I don't want to underscore the importance of what it is that we need to do to battle this, but it's just an infection, and the human race has gone through many pandemics in the past. This is one of a kind. It's global and nothing like we have ever seen, but it should not stop us from doing what we already know we are good at.
Thank you very much, Dr. Shah. That was very informative. Coming to our next segment, I would like to ask Dr. Saras and Dr. Shah, both of you, you can share your thoughts here, but CDC is recommending that travelers avoid all non-essential travel, international travel or any long travel. My question for you, Dr. Saras, what is the current situation?
So international travel is not happening. It's as low minimum. Only if you need to go, you're traveling. And most of the countries, if I can talk about India, India is closed for all commercial planes landing there. So it's only chartered planes which are landing in India. And US also, most of the planes, most of the airlines, they've actually come down a lot on traveling. I don't even think there's only minimal international traveling which is happening, and most of the majority of them seem to be chartered flights bringing goods for us like masks, PPEs from China or any other countries. That's what is happening right now. But to answer your second part of the question regarding what cautions need to be taken on long travel, once the travel opens up, I think I would strongly advise and suggest only if you need to go, you should be traveling. At least this is for the next few months. As Dr. Shah was mentioning, the second surge of the coronavirus, that's what we need to be really careful about. Yes, we have to think about what's going on now, but we also have to think that we shouldn't be going back into a second surge of this coronavirus going on, second wave. We don't want that to happen at all. So it's important to take all the precautions. If you do have to travel, once the travel opens up, I would strongly suggest please make sure if you have any medical illnesses or comorbidities, and you have to take care of all your medications, be compliant with your medications, make sure your blood pressure, your diabetes, everything's under check, and you'll kind of build your immunity by taking all those measures and being compliant with your medications. And it's also important that whichever country you're traveling to, you'll be traveling only most of the time only to see family. That's what I would think, or maybe on urgent business, which you can't do via telemedicine, right? Or you can't do via infrastructure, the Zoom meetings or any of those. So really important, wherever you're going to, if you're going to go see your family, please make sure you check. If I'm going, I would make sure that I don't have the coronavirus. I think I would get tested if I'm going on a long haul travel, if I'm flying all the way to India or anywhere else, and I would make sure that I'm not an asymptomatic carrier. I would check myself for COVID-19 before I board the flight. I think that's the first and foremost thing I would do. And then making sure once you know the travel regulations, what is happening at the other country, whether India, for instance, a month ago, they said, if you travel from US and came, you have to be at least 14 days, stay home, don't go anywhere, stay in the house itself. So those are the things you need to be aware of. And while traveling also, please make sure you carry all your necessary sanitizing tools, I would say these days, all your sanitizers, and making sure that you're wearing a mask, your gloves, and making sure you take only minimum things what is needed. So usually few of the airplanes, what they have is if anybody is coughing, this was even before the pandemic, if anybody is coughing or they have any such symptoms, right, they clear few suites around you just to make sure that you're not coughing on others and they don't get infected. So what the new air caps, they do is 50% of the air which is circulating within the airplane is within the airplane, and 50% is taken from outside. And they have good filtering systems. The filters for funguses, virus, and particles. That's what they usually do. And they have something called a rapid airflow system, where it's not like the whole air is traveling all around the aircraft like this. That's not the way it seems to be happening. So it's closer to you. They have vents. They have one on the ceiling and one at the bottom, and the air is circulating close to your seat. That's what they have actually, and that's in the newer aircrafts. So it's really important to make sure that nobody is coughing. You take your precautions, wear your mask, clean your seat, and take all those measures. And first, as I mentioned earlier, please check yourself before you go for the COVID-19 testing. Please make sure that you don't have it. As a good Samaritan, that you're not going and spreading it to anybody else, and you take precautions so that you don't get it too. So both are really, really important. That would be my strongest suggestion.
Thank you, Dr. Mupanna. And Dr. Shah, do you want to add any other points for protecting oneself?
Yeah, I think as Dr. Mupanna just mentioned, I think checking yourself is one of the difficulties everyone is having. If you are asymptomatic, there is still a shortage of the test. But if you are traveling, I think you should talk to your provider, and they will, if not the antigen test, I think recently the antibody test was just made available via Quest and some of the other labs. So that is something we are looking into in our organization. But yeah, I think what I would not be surprised to see in coming months is recently from the economic downfall, a lot of the airlines are already announcing their new policies and procedures around infection control. That just like at a medical facility, your temperature will be taken, you will be given a mask, like you will see some drastic measures. What we apparently saw after 9/11, what happened with the TSA and the airline security, you will most likely to see this within the airline industry also in coming months. I would not be surprised if there are strict airline or airport infection control measures are being enforced as a region rather than just being dependent on consumers such as us having access to the mask. Because we do this in medical facility. If you walk in, you are given a mask. We ask patient, if you have a mask, please put it on. But if you don't, you stay in the car, you call, no one can walk in without talking to someone. So I think there will be a lot of pre-screening happening. You will be given a lot of information before you travel. But I again go back to the travel has to be individually determined. If you have a single parent who is elderly in Florida and you are traveling to get them back home here so you can take care of them, is that an essential travel? I would argue yes. But if you are going there for 4th of July vacation, think before you plan those kind of travels.
Right. Just to add one more thing, Pratima, thank you for that, Dr. Shah. In our hospitals and most of the facilities, even when you go cafeteria, they're giving meals, right? Because most of them are indoors these days. You don't have our cafeterias, our regular cafeterias has been closed for a long time now. So they drew lines 6 feet, okay, and they have the markers, even to stand in the cafeteria line. 6 feet, 6 feet. Maybe that's what we're going to see in the lines also when you're waiting to get your boarding pass and things like that. And I was just wondering, as we were having this discussion, whether they'll have only limited seats, making sure not the flight is totally overbooked. Maybe that's something that travel agencies, airlines also will think about. And I think even when the travel opens up, they're going to have some rules and clauses saying only essential travels, and maybe you need to show a document that it is an essential travel that you're traveling for. So these things could come up, as Dr. Shah was mentioning earlier.
Thank you very much. Very, very valid points, Dr. Muppana and Dr. Shah. As the COVID-19 virus is creating havoc now, with the entire healthcare system, and very well as physicians now, telemedicine, everyone knows, our viewers know now, is stepping up into the spotlight and helping healthcare organizations and healthcare providers to better to respond to the needs of Americans and everyone in general who have contracted the virus. And I'm talking with respect to America. So Americans who need to touch base with their providers on the status of their health, telehealth is helping, but we need to know more about it. So my question again for you, Dr. Saras, how next of COVID-19?
So I'm going to actually in the sleep medicine world, there's a lot of telemedicine was going on a few years ago itself. So I'm kind of familiar with that part of telemedicine. But now with the pandemic, but I did not install it in my practice, right? I have 2 different locations and I travel back and forth. But now with the pandemic, it's become so important because you do not, it's mainly the social distancing and maintaining the distance, and you don't want to spread the COVID-19 virus. It's become a necessity now. And I feel it's a great opportunity for all of us to have as a provider and also as a patient. When I look at it both ways, I feel it's a great opportunity. Let me talk to you about as a patient, right? I don't want to miss my appointments. Okay, so I want to keep my appointment, speak to my specialist or speak to my primary care if there is a problem. And I want to have still the flexibility of, yes, I cannot go outside my house, but yes, I can still see the doctor, get his opinion, and see what else can I do or need to go for testing or whatever the condition might be. And even for the kids, the vaccines, they go by the calendar, right? The vaccines can't stop because there's a pandemic going on. If they need the vaccines, they need the vaccines. So there are so many things and emergencies, of course. And I feel telemedicine from a patient side has become very, very valuable and priceless. It keeps us so connected to our primary care providers. It keeps us connected to what's going on with a specialist also. And I feel it's a boon. It's such a blessing we have this platform. Coming to the provider side, yes, once we started this, if I'm thinking about March, end of March or something, we were little one foot on one boat and one foot on our other boat, not able to decide which platform to use, which platform is HIPAA protected. We also, I mean, with huge respect for patient confidentiality, we want to make sure it's nobody is hacking into our system. And there are so many concerns and thoughts, right? But now I think over the past few weeks, it's been such a rapid learning curve for all of us. Learning about the telemedicine, learning about the virus, dealing with emergencies. So many things were going on in our lives and rapidly at a rapid pace. So I now, after 3-4 weeks, I feel in my mind as a provider, I feel much comfortable using it, more settled, and the patients are also more aware about what telemedicine is. And what we do is as we are calling the patients and they're calling us, we offer them that this is a platform which is available. So the patient education is also very much appreciated. And we send them information, we send them blast emails that don't be afraid to call us. Just go ahead and call the doctors when you need them. So it's come a long way. I should say it's come a long way rapidly in 6 weeks. I'm going to leave it to the expert here, Dr. Shah.
Dr. Shah, you please take it out from here. And then also, along with, if you can explain also how are hospitals adapting to telemedicine during this pandemic?
Yeah, absolutely. I think, so let me take a step back. And I think for community, the biggest thing which we have seen in last 6 weeks is what we could not do in last 6+ years has been forced down, whether we like it or not, for the patients and providers. Good, bad, or indifferent. I think there are a lot of positive stories, but there are also limitations from telemedicine. So I think the biggest change which we are going through is in the previous state, there was an association between a patient and a provider being in a physical environment where you are able to touch, take a pulse, take an examination. And this is what we call the art of medicine. The science of medicine and art of medicine was quite natural to experience when you are in a physical environment in the same physical space. That became a kind of a struggle in the digital environment because we were not trained to practice the art of medicine and science in a non-physical environment. So I think in last 6 weeks, a lot of the clinicians have gone through rapid learning curve. And this is a transition I call the art of healing, or the healing touch is becoming a digital caring. So we are actually carrying through digital world now. And there is a lot of creativity, which on a provider and patient side, we are seeing. We are seeing, some of my providers are seeing a surprise tour of patients' home, where they actually see the home situation with their medication cabinet, their home environment. There could be an elderly who has an increased risk of fall. And now that you see the home environment, as a physician, you are getting the eyes and ears through telemedicine inside patients' home environment. And there is a huge value to that. Now it is becoming also possible to engage other family members in the care of the patient. Before, patient had to drive to your office, and maybe a daughter could not join because she could not join at that time. Now they can pre-schedule it. The daughter could be in a different place and a patient could be in a different place, and they can all join the same call, just like we are doing right now on the Zoom. So we are seeing a lot of ways the telemedicine is giving us the opportunity to connect. Now, but taking a step back, I think this is nothing new. I think a lot of the telemedicine concept existed for years. If you were part of a healthcare system and you called the answering service and got an on-call doctor 24/7, that is telemedicine. The only difference now is the obstacles have been removed by the insurance companies. The obstacles have been mitigated by the regulatory environment. Majority of the obstacles, there are still 10-20% obstacles left, but what we have seen in last 6 weeks is a tremendous amount of obstacle removal, especially in Massachusetts. I believe on March 16th, Governor Charlie Baker announced parity, which is what it means is whether you get care in a physical office or physical environment in hospital or via telemedicine, the healthcare system will be reimbursed or get paid at the same rate. And I think this was one of the biggest reasons why a lot of the healthcare system were shying away from trying out technology. The telemedicine has various components. One is it could be as simple as triaging via a text or just an audio call or a video call, or it could be just simple as your doctor is collecting data from your blood pressure monitor at home or the weight scale, which is a Bluetooth enabled, collecting the data into the application and going to the doctor. And suddenly, if you have a congestive heart failure, doctor gets to know in real time that you have gained 5 pounds in last 2 days, and we can make an intervention before patient even knows that they are going into a downward spiral. So there are a lot of advances we are going to see in near future where patients will be given some tools at home, whether it's a blood pressure machine or an oxygen pulse oximeter through their healthcare systems. And I think a lot of the hospitals are doing that today, even before COVID, for their high risk population. When you get discharged from the hospital, as Dr. Mupana mentioned, now you need to monitor them at home. How do you monitor them? You monitor them via collecting data through secure environment and do telemedicine. Now, as a general community, how do you access telemedicine? And this is one of the most common questions we get asked as part of the healthcare community. My best advice would be start from what you already know. If you already have a primary care doctor, call their office and see if they've already implemented telemedicine. 9 out of 10 times the answer would be yes. In last 6 weeks, everyone has been forced to implement telemedicine. If you do not have a primary care doctor and you happen to have an insurance, such as I have a PPO, and let's say a lot of the insurance allows you to see specialists directly. Reach out to any specialist you want if you have a direct PPO. Again, 9 out of 10 times they will be providing telemedicine. If you do not have insurance or you do not have any doctor, then ask your friends and family. Someone would be able to direct you to an appropriate care provider. And if you don't have any of these resources, I was pleased to see the news which came out yesterday from Commonwealth of Massachusetts, that Commonwealth of Massachusetts partnered with a telemedicine service provider company called Doctor on Demand, especially for individuals who have no insurance.
Right.
If you are a Massachusetts resident and you have no insurance, for example, you have a parent visiting from India and they are stuck here due to travel limitation, you could be using this app and getting a care directly. It is not so much about the free care, but it's about having the free and open access to getting the care at the right time. And I think with that, I would pretty much like to open it up to the audience if they have any questions. But I think I do see a lot of value of providers and community working together in this difficult time. And as the restrictions are getting slack in some of the states, hopefully we will see early promising sign from the treatment and vaccines over next few months. And hopefully in Massachusetts, we'll be able to also practice safe and efficient medicine.
So, yeah, thank you very much, Dr. Shah. And as Dr. Shah mentioned, it's again for all our viewers, it's about the Doctor on Demand. There is a website which is given by Dr. Shah, which is doctorondemand.com, which will be also put up, eventually on the website too. That will be giving a lot of information. And also there is another resource by Dr. Shah. I think Dr. Shah, you mentioned about a news article, right? So even that will be, that will be big, very, very big resource, which we'll be sharing with all the viewers. But before we jump to the segment where we're going to ask the general participants to ask, could you please, one of the question I want to know, what are the limitations of this telehealth?
Yeah, so thanks a lot for bringing that up. I think this is, I would like to say there are limitations on both sides. So for clinicians, so when any of my providers who I work with or I talk to, any of my colleagues, the single most limitation or the recommendations we give is from a scientific standpoint. If you think you can make a safe and scientifically sound treatment recommendation without touching the patient, then telemedicine is right for you. You do not have to go an extra mile and try to be too creative, because if you need to examine someone's belly because they have an abdominal pain, you need to examine the belly. So if you don't have a means of touching the patient, then telemedicine is not the right avenue for that care model. But for something simple as you have conjunctivitis or you have a sinusitis, we are seeing a lot of creative ways, because for me to examine a patient's sinus, all I was doing as a clinician, pressing on the sinus, which now I can ask my patient to do it themselves. Same thing with, as Dr. Mupana mentioned about the skin rash. If you're doing a video visit, you can actually show the rash to the provider, and the rash can be diagnosed, because majority of the rashes, you do not need to really touch the rash to diagnose what it is. There are advances in technology, but not easily available, where you can listen to the lungs and heart also with some of the gadgets which can connect to your iPhone or smartphone, but those are not freely available. So if someone is having difficulty in breathing and the lungs needs to be examined, in those instances, telemedicine can be a quick triage where a doctor or a nurse can advise the patient that you need to be seen right away. We are seeing some creative applications of technology where there are applications for measuring heart rate and measuring pulse oximeter. Those are not medical grade devices. So I do caution providers and patients completely making their judgment on it. But those are quick screening tools you can do. Especially the medical grade devices are also available to at least check the heart rate, blood pressure. You can get blood pressure machine from any local pharmacy, which are quite accurate compared to what we do in the office also. So heart rate, blood pressure, weight, some simple examinations can be done. But anytime you need to touch a patient, this is where telemedicine becomes limited. And I think we are seeing limitations from the community side, because we assume a lot just because we have smartphones and tablets and internet that everyone has it. Not many individuals have internet. Not many individuals have a reliable internet. And even if they have internet, not many individuals have the up-to-date devices at their home where they know how to use the camera and mic for many of the telemedicine platform. We are seeing some limitation where a doctor or a patient, after 5 minutes of IT troubleshooting, they just revert back to an audio call, because technology is not as simple as doing a FaceTime, which is part of the reason current environment during pandemic, the government has lifted HIPAA waiver. So while for emergency, FaceTime and non-HIPAA compliant platforms are okay, we do have to invest some more effort into building a proper infrastructure where these limitations can be mitigated on a patient side. So we have a long way to go before we mitigate the connectivity and device dependencies, because everyone has different types of devices and access to network at their home. Some of them live in rural places where there is nothing besides cellular or the satellite internet.
Right. So, Pratima, can I add something?
Please, Doctor.
Sure. So, yes, as Dr. Shaw was mentioning, doing this every day is so challenging. At times, you feel so, as a provider, you feel so drained trying to teach the patients to use the technology. And after all that troubleshooting, after all that methods, still we come back to the landline. Most of our senior patients, especially, we found this, that they can be really tech savvy because they have grandchildren. They would have already installed the apps on their phones and they do video calls already. So that's been such a blessing. But at the same time, there are also patients who are not able to use the technology as much, and all they have is a functioning landline. So what we do is trying and call them on the landline, but as provider, we are also having a heightened level of awareness. With We are not able to see them. All we are able to do is hear them. So watching all the time. Okay, are they short of breath when they're talking to me? Are they coherent? Are they answering my questions appropriately? And do they sound as though they're in any distress? Okay, so these are all the things that as providers we are also learning to keep a heightened sense of awareness when we are doing audio calls. And is there somebody else beside them? Is a family member is talking in the background? Okay, good, there's another member there, right there. Or is the dog barking? We are also, as providers, we are also learning all these things, right? And at the same time, when we are doing the video calls, yes, it's great that the government has actually lessened the Privacy Protection Act. And previously, we could do telemedicine only in the state the patient. If I'm licensed in Massachusetts, I could see a patient by telemedicine only if the patient had a living residing address in Massachusetts. But now, even that has been waived. I don't know for how long. I can see a patient who resides in Rhode Island or New Hampshire. So that's one thing which has come up as well by the state. So that's helpful. And for skin rashes and dermatologies, there are certain tools. So at the phone, one of my other friend has. So this is an iPhone I have. They have a small telescope, and you take a picture. The picture has magnifies it so well. For I'm talking only about the skin lesions. Even if you see it face to face with the naked eye, you won't be able to see such a clearer picture as you're seeing it via the telescope on your smartphone. So there are pluses, but at the same, I had a patient the other day who was having acute abdomen pain in her belly, and there was no way I could do a telemedicine visit. Of course, I spoke to her ahead of time, making sure what was going on and everything, prepped her up. Then I knew I can't complete my visit without touching her belly. As Dr. Shah was mentioning, that was the time when we called her to the clinic, checked her out, and sent her to the ER to rule out an appendicitis. So those are certain situations. But overall, on a majority, yes, telemedicine does have its little pitfalls, but overall, for now, I feel it's working.
Right. Thank you very much. It was very, very informative information we got from both Dr. Shah and Dr. Mupana. But I think I'm pretty sure our participants will have more questions to ask and open-end questions. So we will move now to our next segment of definitely requesting our participants to go ahead and ask a couple of open-ended questions. So I'm trying to see here, do we have more participants who would love to ask any questions here?
I would say that participants should unmute their microphones to ask any questions. But to begin with, we have a question from our Facebook viewer, Gopinath Jale. Is it possible patient can recover from ARDS and start breathing? My uncle is affected on full ventilator and have ARDS.
So I think Dr. Saras?
Yes, it is possible. Okay, it depends on what other comorbidities that your uncle could be having. Okay, and if there's any history of hypertension, diabetes, or it depends on other things like heart problems, any transplant issues, any medications which are suppressing the immunity. So it has to be put into context. It's on an individual, every person and patient is so different. So we have to keep all those into consideration. Yes, there are so many success stories where the patients have come out of ventilators and have been discharged home as well, even from my hospital. Okay, so hope and faith, it is scary. I totally understand that. And it's a very, very valid fear to have now with this COVID-19 pandemic. But faith and hope are also going to get us to the other side or the brighter side of the tunnel.
Thank you.
Is there anyone more who's having any more questions? I think everybody's on mute.
While we are waiting for that, I wanted to share one simple thing. Okay, so this is a pulse oximeter. Usually, you can buy a blood pressure cuff from any stores. Dr. Michelle was mentioning about Walgreens, Costco, BJ's, anywhere, Amazon, wherever it is. I think it's important to have a blood pressure machine at home. Okay, it's not the most accurate one, but it is good for now and it works. Okay, that's one part I wanted to mention. And this is a simple tool. It's a pulse oximeter. It was around $25 or $18 to $20 before, but now the price has gone up. It's almost like 40, $50 now on dollars now. And what it measures is all you have to do is put one of your fingers, okay, into that. Please make sure you don't have a red color nail polish. It'll flaw the data. Okay, and it's a simple device. Turn it on, and then you'll be able to measure two things. One is your heart, your pulse rate, and the second one is your oxygen numbers. The closer they are to 100, that's the best you can get. Okay, 96 to 100, anything, all those numbers are good. But if a person has this shortness of breath, cough, fever, and COVID-19 positive, or even otherwise, I would strongly suggest that they check their pulse oximeter at times. Okay, and even when you're doing your phone call visits with your primary care, and if you have the device, the primary care may or may not ask this question, but please make sure that you tell them you have a pulse ox and you can measure your oxygen numbers and you can let them know during the same visit. Okay, so this is how it measures. So you can see my heart rate is 63, which is at the bottom. And you can see my pulse oximeter is somewhere around 98, 99. Okay, closer to 100 is good. So I would strongly suggest that patients buy this device. It's available in the market.
And Dr. Mupana and also for Dr. Shah, this is a general question which some of the people asked, not today, but they wanted to know, like, if someone in their household is quarantined, right, what should they do? They're a little worried about it.
Quarantined or isolated?
Literally quarantined, like the family member got COVID, whatever, corona, and they kept in some other room for them. So what are the other members supposed to do?
So if the person has COVID-19 positive, okay, that's isolation. So they have to isolate themselves in one part of the house, okay, and wearing a mask and have their own bedroom, bathroom, own utensils, put their clothes in laundry. And they're secluding themselves to one part of the house because they don't want to give it to the other members in the house, like kids, elders, parents, anybody. They don't want to cross-contaminate and give it to anybody else, right? And somebody is going to take care of them. Please make sure you go and look after them as well. That's important too. And please make sure you wear your precautions, like a goggle, okay, eyeglasses, and a mask, a good fitting mask. And it has to, the mask, I know most of them don't have access to the N95s, and it's okay to use surgical mask. If they don't have access to surgical masks, many of them in the community is doing an excellent job here, the local Massachusetts community. They're sewing masks, something like this, like a little thin metal film. So what you do is when you have this, you have to pinch your nose so the air particles are not going in, and you're also not releasing anything to the environment. So that's important. That small metal clip, they can have a small metal clip incorporated into sewing masks. Something to think about. Okay, and making sure whoever's coming to take care of them, making sure that they goggles, the mask, and the gloves. And once they take care of the needs, come back, have a shower so they don't mingle with the rest of the family with the same clothes or carrying the same things. Whatever utensils or whatever you're giving, the surfaces is one major reason for contamination, right? That's one major, huge reason, actually. So you have to take care of those. Those utensils have to be kept separate.
The question for you, Dr. Shah.
That's isolation. But if the patient is suspicious but not COVID-19 positive, we don't know, suspicious, then you quarantine yourself, right? And you do have to take the basic precautions even then.
Yeah.
Just to differentiate between positive and negative. And patients who have all the symptoms, but the COVID-19 testing came back negative, please do not think, yes, you're negative, you're not going to be contagious. You could still have a false negative test. Continue to take your precautions, please.
So,
Yeah, I
Dr.
was going to highlight there are 20% false negative rates in the community right now we are seeing. So if you were given a COVID test and it came back negative, do talk to your provider, because if the suspicion was high, they might still ask you to at least practice isolation if you can, even though the rapid test was or the antigen test was negative. But hopefully in near future, we should have the ability to get IgM antibody. Right now, to my knowledge, it is not available here in a local market. Yeah, and there are a lot of mixed data coming from the antibody testing too, but I think pretty soon we'll have some clarity. I think the biggest thing is if you have someone in the family who is immunocompromised, someone who is on a dialysis, someone who has cancer, and one of the healthy young individual got COVID diagnosis, that's when the heightened level of isolation is kind of a mandatory recommended, because there is a high risk when you have someone in the house with COVID who can give it to your vulnerable population, what we call people who already have pre-existing low immunity. But that doesn't mean if someone has COVID-19, they need to be completely taken out of the house and go somewhere else. Like, you can take care of your family members in the same household, just like we did back in India at home. Growing up, I remember if anyone was sick, we kind of pampered them. You don't need to do this. We'll feed you. We'll take care of you. So like something similar to that, but to Dr. Mupana's point, they need to be in one part of the house as distant away from the rest of the family members as possible.
Coming to that point, Dr. Shah, do you think, I mean, this is again a question by a couple of our viewers too, like if anyone in their house survived Corona once, could they be reinfected?
I think this is a tricky question. I think the current literature suggests that if you have an antibody, it is not a guarantee that you have immunity. They are seeing cases of reinfection, I believe in China. Dr. Mupana might know better, but I don't think it is 100% if this, then that. Like, so if your antibodies are positive, it does suggest by 90 to 100% specificity that you had an infection, but we don't know what the numbers are for immunity. Time will tell as more tests are getting done, what is the true immunity from the antibody test.
Dr. Mupana, can you please explain, if you can, about this?
Sure. Co-infection, reinfection. Now, to talk about the reinfection part of it, whether you can get COVID-19, at least initially, once you're COVID-19 positive, your body is mounting a response. That's where the antibodies come into play, right? And the antibodies are going to be in the bloodstream for some time, weeks, or we don't know for how many weeks or for how long, we don't know yet. Okay, they're going to be in the bloodstream. During that period, the likelihood that you can get reinfected by the same strain, same mutagen of COVID-19 is less. However, the COVID-19 seems to be acting a little strange. There could be a mutation there, a slight mutation, a slight change in its genetic structure. Maybe you could get infected with that one later. That is a possibility. So this is all theoretical. We still don't have any confirmed big trials which say, yes, this is what is happening, or this is what we are seeing in a large patient population. We don't have that kind of data, but reinfection could be because of a mutation within the COVID-19 genetic material. That's one big possibility, we think. But otherwise, initially, when you get COVID-19 positive, for a few weeks at least, you should be having your body's mounting a response. It's forming antibodies. So you should be able to fight the same COVID-19 structured virus again. And just touching base on the co-infection. So COVID-19, just like previously, the viruses, right? And you take influenza A, influenza B, or the RSV viruses, what happens is they can have coexisting infections with a bacterial like strep or staphylococcal, any infections that can happen. So I've seen a mix like influenza positive, influenza A or B, they could be positive. Then few weeks later, they could be COVID-19 positive. Okay, so I've seen that in my practice, and I've also seen COVID-19 positive, and then they're having influenza A positive now. I know it is April, it's a little late for the flu season, but last year we've seen a lot of influenza A and B positives late into the spring. So we're just waiting and seeing. We want to wait and see how it's happening this year regarding co-infections. So other viruses can happen, can occur with the COVID-19.
Ramakrishnan, do we have any participants who have any questions that they would ask our physicians here?
I believe Raghu, I think in the name of Hansika. Raghu, do you have any questions? Understand?
Hi, this is Raghu from Bloomington, Illinois. I'm Ramesh's friend. So, quick question. How do you normally treat a COVID patient without any underlying conditions? Like, is there any general treatment in terms of food or medication you give to, have the patient recover?
Can I take this, please?
Yes, please,
Sure.
Dr.
Sure. So this is Saras here. The most important thing is we have to understand the COVID-19 patients, the mild to moderate cases are majority of them, fortunately, right? 80% of them, of these cases are mild to moderate where we can take care of them at home in an outpatient setting. It's the rest, like 18 to 20% are the patients who are severely ill and critically ill and need to be hospitalized and need to be monitored. Coming to your question to answer whether food can help, yes, absolutely. We all know that food is medicine, but that's not all. It's mainly helping to build immunity. It is not helping to cure the coronavirus 19. I do want to stress the big difference here. So, general immunity boosters, good health, vegetables, and fruits, hydration, adequate sleep, level reduction by meditation, whatever works for you, and exercise. These are all general measures to help boost your immunity and to bring your stress level down. So, those are general measures which are going to help us with any condition, any disease for that matter, right? That's one part. Regarding to answer your second part of the question, what medications are helpful so far in an outpatient setting? We don't have, I'm not prescribing any specific medication for an outpatient. If they need medications like hydroxychloroquine or azithromycin or a combination of these medications, they are hospitalized. They have to be, you need the blood work, you need the blood work to support it, you need the chest imaging, chest x-ray, CAT scan of the chest. You need all these supporting things to see, and EKGs to make sure they don't have QT prolongation. We have all these things. We need to do all these things. So they are hospitalized patients only who are getting all these treatments.
Thank you.
Keep it brief, right?
So, Dr. Shah, do you want to add something to this? Do you want to give any more points here?
Yeah, no, I think the guidelines have been put out from many scientific bodies. And in fact, the National Institute of Health also recently put out guidelines which are combined from many of the organizations, which is exactly what Dr. Mupana just mentioned. I think we forget at times that mild to moderate condition does not need any cure. And when it talks about, we like to talk about cure in medicine a lot, but there are very few things which we have actually cured. The biggest, the difference between cure and treatment is cure is once you take care of it, it never comes back. So we have cured smallpox, right? We were on the verge, and I believe we have cured polio. I could be wrong, but I think we were on the verge of curing polio from the entire world also. But for the most part, apart from vaccine preventable conditions, we manage conditions. We don't cure things. Diabetes hasn't been cured. Blood pressure hasn't been cured. So while remdesivir is an excellent drug, in my opinion, even though I've seen personally a couple of our own colleagues in ICU, intubated, and now ventilator support has been taken out. We have seen 90-year-old family members, parents respond to remdesivir also. So while I have hope in remdesivir for a compassionate and critical care, and including hydroxychloroquine and azithromycin when it's done safely, this is not something where everyone should be just taking hydroxychloroquine. I usually caution everyone, even when they travel to India, to take which malaria prophylaxis to take. You should talk to your doctor. You don't know which is the best regimen for you. Every drug, azithromycin and hydroxychloroquine, both prolong QT interval. So those are decisions which doctors have to make by taking all the data points and history. But I think the only thing I would like to add is, if you are diagnosed with COVID or not, what we are seeing now is there is a general awareness for how to boost your immunity. And I think everyone is practicing to a certain extent, including myself, because there are two things all Americans were highly affected by. Number one, chronic dehydration. We as American community, and I think I can't speak for global, but we know the data from the US that we did not do a really good job drinking water throughout the day. And I think by staying home and practicing a lot of food and life balance, hopefully one can hope that we are drinking a lot of water regularly. The second thing was physical inactivity. And I think being at home, that is a very high risk now for people to become physically inactive. Just because you cannot get out freely like you did before, it should not stop you from doing a walk in your backyard when the weather is nice, or walking on your treadmill, or just going out in your neighborhood with safe distance and wearing appropriate precautions. So, stay active, drink water, and use food as a medicine. Practice mindfulness, whichever practice you do for faith, that will keep you closer to your hope environment. And those are the key even when you have COVID. Uh, Deep breathing exercise for 1 minute a day has been shown scientifically to improve immunity. Just 1 minute of deep breathing exercise has shown the immunity improvement. So I think we should all be practicing some of those. And I think those are the things we are seeing that becoming really helpful for COVID patients. This is what I advise when they are home, to exactly practice what they should be practicing even when they don't have COVID.
Before we go to any other question, Dr. Saras, Dr. Mupan, I have a question, because this is something which is lately going on all over the place, where even physicians are asking for the convalescent plasma. I would love you to once again tell to our viewers that even if they have been tested before, or they had COVID, and after 28 days, if they want to give plasma, it's not going to affect their health anyway. So could you please let our viewers know more about it?
Sure. Thank you. So along with remdesivir, convalescent plasma also seems to be promising for the patients who have COVID-19 and critically ill patients who are in the intensive care on ventilators. Every institution, health hospital has its policy, so it has to go through the panel, right? And you all can go to fda.gov. You can also go to CDC, and you can go to Red Cross. Okay, those are the common sites where it's given. You have subdivisions: plasma donors. As a plasma donor, there is a tab for that, and as a recipient, if you are affected or family member is affected, and you want to see if you can find a suitable match for them, there's another tab for that as well. So you can get information from these websites, and I can share them with Pratima to put it on the Facebook site too. But you have to be more than 17 years of age and a certain weight. I think it's around 120 pounds or something. You have to be more than that. You have to weigh more than that. And you have to have COVID-19 positive test. Proven positive test. That's one of the first requirements, right? After you fulfill the other inclusion criteria. So once you have that, then there is a criteria. You have to have at least more than 28 days from the time of your symptoms. And it could be 14 days from the time of your symptoms. You're symptom free. You have to be symptom free now. You cannot actively have symptoms and your still body is making the inflammatory markers, and that's not the time for you to go and donate the blood. It'll be later. The time will come, maybe 1 week from then or 2 weeks from then, right? And 14 days of symptom free time, plus a negative follow-up COVID-19 testing. You should be a COVID-19 positive first to be even eligible, right? From that time span, 14 days of being symptom free and negative test. So that's one criteria. The other one is 28 days from the time of symptoms and you're symptom free too. Okay. So there are criteria. They are also even the CDC and the Red Cross, they're also making subtle changes to this according to what the research they have. So please go and check on the Red Cross website. They'll be able to give you the exact details for that. Research has shown that papers in research literature has shown that giving the plasma seemed to be helpful for the body to fight the virus, right? That's what is happening. The virus is COVID-19 is replicating within the body and producing the cytokine storm. So when you give the plasma to these patients, it seems to help. But now what, as a healthcare community, we are looking into is, can we even give it a little bit earlier? So we give the plasma a little earlier in the critically ill patients and severely ill patients. Can we give it a little earlier so we can avoid them getting intubated, going on ECMO, going on other life-saving measures? There's still a lot of controversy regarding the timing, and still a lot of policies are not in place, but it is getting more promising. As Dr. Shah was mentioning, we have a few of our colleagues who have received the convalescent plasma and they are stable now. So that's the one thing I wanted to share about plasma. And if anybody, I want to put it out to all our community, all our Boston and Massachusetts community, if any one of you or anyone whom you know are COVID-19 positive, please ask them to help the other patients. Please make an altruistic donation of your plasma. I would humbly make this request to all the viewers and to all the whole community as such. If you or you know anybody who's been COVID-19 positive, please see if they can be a plasma donor. That'll help so many. One plasma donation can help up to 2 to 3 plasma recipients. 2 to 3 patients can receive it. So it's really important that as a community we come together and see how much we're able to donate the plasma.
Thank you very
I
much.
have one more question from the viewer, Rajini. She's asking, I'm a regular blood donor. Is it safe to do blood donation these times?
Again, I think Dr. Mupana, if you can take this.
Sure. Thank you, first of all, for being a blood donor. I think it's so important. You're really saving patients. And yes, you could do the blood donation. Please, whichever blood donation center you go to, call them first, schedule your appointment. They will give you all instructions on how to come there safely, what timings they're doing. For some reason, if they're closed, they'll refer you to another bigger blood donation referral center. And please take all the precautions. And they will also take their precautions. They're going to check you for the COVID-19 as well, along with the HIV, the regular blood donor testing like HIV, hepatitis C. They will do all those regular tests, and they will also do COVID-19 testing through the blood or through the nasopharyngeal swab, whichever the test is doing.
So, Dr. Shah, do you have any thoughts in this?
No, I was just going to mention that I think especially if you have a rare blood type, again, this goes back to just because we have coronavirus, the other problems haven't gone away. So if you have a rare blood type, definitely continue donating if you can. And as Dr. Mupana just mentioned, I think if you haven't had COVID-19 test through the blood donation process, you might end up getting it, because I think now it is becoming, I can't say for sure, but it is becoming a standard of care for blood donors to also get screened for COVID-19, at least for now.
Right. Not that you won't be getting the disease, you'll be getting the testing done.
Testing.
Right.
So is there anyone else, Rama, if anyone wants to ask any more questions?
I guess we are good. I think we are 15 minutes, almost 13 minutes over an hour. It's been a good
But I would definitely ask our viewers, to also think about all our sessions that we had till date. I think this is the 7th session. And it'll be very nice if most of the participants and the viewers can actually email us to, also share your thoughts about how the sessions went, and if you had any other questions, to covid19@tagb.org. But before that, Dr. Mupana and Dr. Shah, could you both give one at a time, of course, starting with Dr. Mupana, your closing statements for our viewers?
Sure, sure. I was reading another article written by Dr. Mark Schneider. He's actually the associate professor at infectious disease here at MGH. So the main take back was, which all of us know, but I wanted to emphasize, there's no proven vaccine yet. There's no proven effective treatment option yet for COVID-19. Okay, but the most important thing that we all know, which is going to work, which is working and which should work, is the social distancing. It's really, really important. Yes, the government thinks about reopening. Yes, I'm not saying Massachusetts, but other parts in the United States, everything, they're talking about all those things. But what should be still continue to be practiced in is the regular hand washing, safe distancing, and wearing a mask, and keeping yourself and your loved ones safe. By doing that, each one of us have a responsibility in this. You don't have to be a healthcare worker to feel responsible. It is not a health, it's just not a medical illness anymore. It's a public health issue. So each one of us have to feel that, yes, let me act like a healthcare worker. Let me take care of myself. Let me take care of my people at home. Let me take care of my community. It has to be it's a responsibility for each one of us. We are all in this together, and all of us have to take care of each other to be able to successfully come out of this pandemic. So that's my humble request. Thank you. And I would like to thank Dr. Ram Mr. Ram, for putting me through. He started the sessions, thinking 7 or 8 weeks ago, and TAGB as well, and the rest of the executive team. And thank you, Pratima, for doing the wonderful moderation. And thank you, Dr. Drumil Shah, for coming on board today and sharing your thoughts and visions. I thank everybody.
Thank you, Dr. Mupana. Dr. Shah, any closing statement from your side to our viewers?
Sure. I think let me thank everyone for joining today. And I think I would like to thank the viewers, especially, and TAGB. The main thing I would love to leave you guys with is this is unprecedented times. I don't think any one of us has experienced going through 1918 Spanish flu. Most of us who went through that are not alive anymore. And I think we are going to hopefully come out of this much stronger as a community. This is my sincere hope. And for the generations to come, we will be telling the stories of how the nation, the global community came together, and how we not only helped take care of our own friends and family, but we contributed back to the society. I think as a human race, I'm a strong believer that this is a huge wake-up call which we have all received. We have been talking about net zero and carbon footprint and so many other, whether you believe in global warming or not. I think whatever happens next, it's all about making choices, and just make the good choices, stay strong, drink your water, get your sleep, eat your food properly, and COVID-19, COVID-20, there will be another coronavirus after 100 years, and we will still be here as human race, and we're going to come out stronger and even more connected than ever before. Stay safe and stay healthy. Thank you all.
Thank you, Dr. Shah and Dr. Mupana. I know before I end this, I want to say in this difficult times, all the organizations that we are with now, Telugu Association of Greater Boston, Indian Association of Greater Boston, again, I'm going to take a TMAID, NATS, which is the Boston chapter NATS. Then we have the Blackstone Valley Indian Society, which is BVIS, and all these organizations, and we are very glad to say, and openly I would say that all these organizations, they came together and still coming together under one common roof, and they're working towards, talking about this common goal in their joint efforts to combat, this novel COVID-19. But of course, we need to know that these organizations and media, I would tell to all the viewers, this is a powerful tool, powerful way, not only of communicating important health messages, but administrating one of the most powerful medicines, and I hope you all agree, that's hope. So I would like to thank Dr. Mupana, Dr. Dr. Shah and I would love to sign off today from COVID-19 7th session.
Thank you. Thank you
Thank
so
you.
much.